WebEx work. Still on vacation. Right. This is what are we doing? It's just not a good morning, apparently. Try this again.
Agreed, it's a bad morning.
It is a bad morning. Very Monday-y Wednesday. It is Wednesday, right? Okay. So respiratory emergencies. Most of your emergencies you should be relatively familiar with because they're less. Quick update of your upper respiratory and lower respiratory tract look like. Test question usually pops up. The division between the upper respiratory tract and the lower respiratory tract is in fact your larynx. Okay. You have two types of respiration. You have external respiration and internal respiration. Your external respiration is the exchange of oxygen and or other gases between the environment and your lungs. Okay? So if you imagine your body as like a big cartoony cutout and it goes into your mouth and uses your lungs, okay, that's external. Your lungs are still directly interacting with the external environment, as opposed to internal respiration, which is between blood cells and tissues, right? Any tissue. That little finger cell right here, that's experiencing respiration internally, okay? You're not getting any sort of level of respiration from the environment in, like, your finger tissues. Always shows up, external versus internal respiration. A lot of different risk factors that cause respiratory disease, right? So we should be relatively familiar with asthma, right? That's an intrinsic problem. Cardiac issues like pulmonary edema, pulmonary embolism can cause problems in respirations or respiratory system. And stress, right? A lot of patients, especially asthmatics, right, will experience, if they're experiencing a stressful situation, will have a worsening of their breathing. Stress could do it, but also indoor and outdoor pollutants or allergens, right, can cause people to have bad asthma attacks. Smoking overall is bad for you. Just don't do it. It causes all sorts of problems and damage to your lungs. Control of breathing is a very complex kind of situation, or process, I guess is more accurate. So you have the central nervous system, right, which controls how you breathe.
Nicole?
Yes.
I'm just going to interrupt for a second. There's a few people that aren't muted and sound is coming through. Can everyone just make sure they're muted?
Cool. Right, so you have the central nervous system control of breathing. So your medulla, you have the chemoreceptors in your aortic notch and in your carotid arteries, which kind of detect how much carbon dioxide is going on in the blood, and it determines how fast and or deep that your body needs to breathe in order to meet metabolic needs. That's also tied in with your acid-base balance there on the bottom. And then you have your central nervous system controls that your breathing rate by moving your intercostal muscles or innervating them and moving the ribs and the diaphragm to expand your lungs. Okay, so it all works together pretty smoothly to make sure that your body is getting the right amount of oxygen. A lot of different things can cause your respiratory system to not work effectively. So we're going to talk about those now. Most of the time, when we talk about problems with respiratory, it's what we call a VQ mismatch. V meaning ventilation, Q meaning perfusion. I know perfusion doesn't start with the letter Q, but that is the medical abbreviation for it. Other problems end up with diffusion, and we'll talk about that as well. So ventilation is air moving in and out, correct? You can move air in and out of a dead body, and it has been ventilated, but it doesn't mean that respiration has occurred. You need to get an adequate amount of oxygen into the lungs for there to be a good gradient for the oxygen to move from the lungs into the bloodstream, right? You need a high level of oxygen in the lungs to pull the carbon dioxide out of the blood, okay, right? You have that, we like homeostasis. We like everything to be balanced. In order for you to properly ventilate yourself through your normal pathways, right, you must have an intact brainstem, right? So patients who have very high spinal cord injuries or have damage to the back of their head, right where their brainstem is, aren't necessarily going to be able to ventilate themselves appropriately. You also need your diaphragm and your intercostal muscles to be, in good shape. So patients who have, chest wall injuries aren't necessarily going to be able to ventilate themselves appropriately. Your upper airway is blocked or damaged in any way, shape, or form, right? So maybe a foreign body airway obstruction or crushed trachea. You aren't going to be able to ventilate effectively. The same thing goes for the lower airway, right? If you have a patient who has hemo or pneumothorax or bad pulmonary edema, right? That lower airway, the lungs, the alveoli, they aren't functional. Here are a number of different reasons that a patient might not be able to ventilate themselves appropriately. Okay, so we talked about some of these already, chest wall impairment on the bottom in particular, right? If the patient is paralyzed or has a bad neuromuscular disease, they might require ventilatory support, right? They might be trached and vented. If you have some sort of trauma, foreign body airway obstruction, young children, tonsillar inflammation, right? Really bad tonsil infections can cause, upper airway obstruction, anaphylaxis. While it's not necessarily a ventilation problem, it can cause upper airway obstruction from all the swelling. Talked about lower airway mucus plugs. You see a lot with patients who are vented, right? Or that mucus that's in there, you're bypassing the airway's normal filtration and warming and so all that mucus that normally lives in your lungs just starts to harden up and become a plug. And then you have CNS impairment, right? So brain injuries, strokes, spinal cord injuries, and narcotics overdoses, stuff like that, all can cause problems with ventilation. For the most part, most ventilatory problems can be handled BLS. Now, as medics, we want to jump to running right to the ALS portion of things. We want to get that tube. But if you can manage the airway BLS, that's not a bad thing either. You want to make sure that you're providing that patient with oxygen and adequate chest rise and all of those good things to make sure that they are, sustaining life. You want to make sure that you are pre-oxygenating that patient appropriately. Pre-oxygenation is not, pump, pump, pump. You are going to actually spend the time. If you can adequately ventilate a patient BLS, you have the time to set yourself up for a successful intubation. I know we get into this emergency situation and we want to rush, rush, rush. Oh, we can only be on scene for 20 minutes, or, oh, we need to get to this patient to the hospital. Those are all valid points. But remember, slow is smooth and smooth is fast. So if you spend the time making sure that you're oxygenating the patient, that you're setting up your equipment appropriately, that you're positioning the patient well, you will have a successful intubation. It will happen quickly, and you'll get to the hospital within that, that time frame that we've all set up in our heads. It will happen. This is when you have to control your own nerves and your own adrenaline and make sure that it goes nice and smoothly. Here's some, we like acronyms, right, in EMS. DOPE. This is one of the primary troubleshooting acronyms that you should remember when dealing with a patient who has sudden issues with respiratory compromise if intubated. So one, displacement, right? Did we now carry this patient down a flight of stairs and somehow dislodge the tube from the trachea, right? Always, every time you move that patient, check the lung sounds over and over and over. You can't be, too cautious in making sure that that's good. You want to make sure that there's no obstruction, right? Is the tube kinked? Is the patient chewing on the tube or biting down on the tube where, they're going to prevent proper ventilation? Is there a mucus plug, which we just talked about? Pneumothorax, right? Do we still have good mouth sounds? Especially in the elderly, once you start ventilating them, you can very easily overventilate fragile lungs. Infants as well, right? Young children can be a little too aggressive with the BVM. You want to check for lung sounds again. And then equipment, right? Is something disconnected? Has the BVM popped off the end of the tube? It happens more than you think. Has the little connector T part popped out the end of the tube? Right? So all of these things are things that you should be checking in the event that you're having a ventilation problem with an intubated patient. So now we have diffusion issues. In order for gases to be properly exchanged, the alveoli wall and the capillary wall need to not be thick, right? So we see that in patients who have really bad COPD, right? They lose all of those alveoli. Those little tiny grapes on the end become one big grape, so there's less surface area, so it's harder to exchange oxygen. The wall of the alveoli is 1 cell thick. The wall of the capillary is 1 cell thick. So it should be easy for oxygen and carbon dioxide to be exchanged across 2 cells. That's not a lot, right? But that also means that there shouldn't be any fluid in between. So if you have a patient who's suffering from like acute pulmonary edema, that fluid works into that space and makes it harder for oxygen and carbon dioxide to be exchanged because of that space between expanding the space between the 2 cell walls. Other issues that might cause diffusion problems, talk about pulmonary edema already, acute lung injuries, COPD, if they have what's called blebs, right? These little pop outs from the lungs, sort of like a lung aneurysm. Those don't exchange gases very well. Any other sort of diseases of the alveoli, okay? Asbestosis, in case you have a class action lawsuit that you'd like to discuss. Fibrosis, any sort of thickening of those cells where they are no longer very easy to fill. It's going to cause problems with diffusion. And then here on the bottom right, there's inadequate oxygen in the ambient air. So basically what happens is if you are in a low oxygen environment like a cave or a non-pressurized aircraft or something like that, you're going to have a lower level of oxygen. So there's less oxygen in your lungs in order to exchange with your blood. Okay, remember, you have to have those gradients where you have high levels of oxygen in their lungs and low levels of oxygen in your blood for it to exchange well. If there's low levels on both sides, it's going to be a problem. This also happens in things where carbon monoxide poisoning or like methane, right? Septic tank issues. When people fall into septic tanks and stuff like that and die, there's no oxygen in that air. So this is where we start talking about how CPAP is super effective. Okay, so CPAP has been found to really reduce morbidity and mortality rates in patients over intubation. Intubation ends up being kind of a long haul in terms of hospital stay. Okay, if a patient is weak and really sick, it's going to take them a little bit of time to wean off of a vent. Okay, the second you take the respiratory drive away from those intercostal muscles, the diaphragm, they get lazy. Okay, you don't work out for a couple days and all of a sudden it's really hard to lift that 20-pound weight. You don't breathe on your own. Switch from negative pressure to positive pressure, which is what a ventilator does. those muscles get very lazy very fast, and you have to kind of remind the brain that it's supposed to work. So CPAP is good because while it's providing positive pressure support, it's not doing the work of breathing. You're still activating your own muscles to take a deep breath, okay? So it does a lot to keep patients from having to be weaned, reduces their hospital stay, and it helps improve that gas exchange by expanding that alveoli and pushing any potential fluid out of that space between the alveoli and the capillaries. Okay, it reduces that by moving that fluid out. It reduces that space back to where they're butted up, right up against each other. Fusion is easy. Now, perfusion issues. Okay, these are the issues in regards to the lung is not getting, either the lung isn't getting enough oxygen, blood flow with a pulmonary embolism, or the heart's not pumping effectively, okay, and it's not getting enough blood to the lungs to actually exchange. In order for perfusion to be effective, you must have a good, appropriate amount of blood volume. You must have an appropriate hemoglobin, right, which that could be patients who are severely anemic are going to be short of breath, okay, because they are having a hard time. They don't have enough hemoglobin, enough vehicles to get that oxygen from the lungs to the tissues. There's no occlusion to the pulmonary capillaries as your pulmonary embolism, and the heart is pumping effectively, right? So if you have your congestive heart failure patients, right, and their heart's not pumping effectively, it backs up from whence it came, back, especially left-sided heart failure, right, goes back to the lungs and creates congestion. It creates all of that fluid buildup. So it's that you're going back into a diffusion problem. Diffusion problem can be caused by perfusion problems. Okay, there's an overlap. All of these issues kind of overlap. Delightful for you guys. One of the best ways that you can help improve a patient's breathing, a lot of situations, is to improve blood circulation. Okay, you have a patient who is, super shocky and they're having a hard time breathing, supporting their blood pressure is the best way for you to help support their breathing issues, right? Because you need to get more blood back to the lungs so that the gases can exchange. The more the gases exchange, the less toxic buildup that they have and the better outcomes that they're going to have. So this might mean that you're giving a patient pressors, okay? You need to look at the whole picture and decide what your best course of action is. A lot of the times, if you have a patient who's hypotensive, you can fix a lot of their problems by fixing their hypotension, okay? And that could be something as simple as elevating their legs. I know we don't want to lay a patient who's having a breathing issue down, but if they're also super hypotensive, you're going to have to make a decision, right? How are you going to best support their blood pressure? Respiratory failure is when the system actually just fails to promote gas exchange, right? It's its whole function. That could be that it's either A, not providing enough oxygen to the body, or B, that it's not eliminating enough carbon dioxide, or a combination of the two. Usually it's a combination of the two. Remember, if you don't support the cardiac output, you're not going to get the carbon dioxide back from the tissues. Your patient's going to be increasingly acidotic. They're going to have a buildup of those lactic acids and all sorts of other waste products that they need to get rid of. And if they're not perfusing well, you're not going to be like blood circulation perfusing well. They're not going to be able to ventilate and have proper respirations. Respiratory failure's got about using fluid before, but depending on what the cause of the patient's hypotension is, yes, fluids are very helpful. If the patient is hypotensive because of something, for like example, like a bad CHF and their heart's not pumping well, I wouldn't want to give that patient fluid. But most of the time, you can support perfusion by increasing the preload with fluids. You just need to make sure if the patient's already full of fluids in their lungs, you don't want to add more. Those are patients who would benefit from pressors. Awesome, good question. So respiratory failure, okay, there's a number of different types of respiratory failure. So you can have hypoxemic, which is when your SpO2 is less than 90%. You will never get to see what the PO2 is unless you're working in the ER. And then you have ventilatory failure when the carbon dioxide is greater than 50. Okay, most of the time, both of these respiratory failures will have a declining pH, and by declining, I mean they're becoming more acidic, right? Because when the number goes down in pH, it means that they're becoming more acidic. Here's some things that cause respiratory failure. Split up by hypoxic, not enough oxygen, or on the bottom, too much carbon dioxide. Things to keep in mind treating your patient. Healthy baby, sick baby.
Was that a question?
Yes, that's a question.
Sick baby.
Give me this. Give me when you look at that kid. Why do you go? Oh, that's a sick kid.
His eyes are closed. He looks exhausted. He can't even hold his head up.
Perfect, right? Exactly. Right? That's one of those windshield assessments. You walk in and you're going, oh no, that's not a healthy kid. Okay. So key signs of what respiratory failure, right? Do you start seeing a patient starting to get really tired? It's not good, right? You should be setting yourself up probably to intubate. Even if you've given them oxygen therapy and their SpO2 is still not improving, you should probably be preparing to intubate. Little kids, you'll see the seesaw respiration, right? When they start belly breathing in and out. Cyanosis, usually not a good sign. Sometimes you can fix some of those problems, right? If it's a narcotics overdose, we can fix that. But as you start to see these other signs of respiratory failure, you should be setting yourself up to make sure that you're going to support the patient, like respiratory, ventilation, oxygenation, all of those things you need to make maintaining. This is an important chart. You should be familiar with this chart. This chart is going to absolutely positively show up. It's going to help you, and especially when you get to the National Registry. Okay. They're going to give you have a patient who has a elevated pH and a decreased hydrogen with an increased bicarb. HCO3 is bicarb. What kind of acidosis or alkalosis are you dealing with? All right, these are questions that you're going to see. This is one of those things that I would highly recommend that you info dump when you take a test, okay? Because you're going to forget, and that's okay. But it's very important that you remember what these are. So generally, when you're dealing with metabolic, when your pH goes down, your bicarb also goes down. Okay, they work in the same direction. When it's respiratory, when your pH goes down, your PCO2 goes up. Okay, you'll see the bicarb and your CO2 are associated, right? And how can you find out what your patient's CO2 is?
The end tidal, CO2.
Perfect, end tidal. So you can inadvertently find out also what their bicarb is by looking at their end tidal. Very good. Primary survey, right? Is my patient breathing? It's usually a good start. A lot of these you should be familiar with already, right? This is BLS. Do I need to do something immediately? Is my patient altered? Is there bad cyanosis? Is the patient able to speak in a full sentence? Tachycardia over 130 is generally a bad sign, right? Any accessory muscle use or retractions, right? Especially for kids. 100% raise, if you were dealing with a small child and you're concerned about their respiratory status, pick their shirt up. You will see retractions, okay? Not enough people exposed to chest, especially in little kids. So make sure you do those things. Getting your chief complaint, all right? Why? What happened? What started this? Have you been sick at all, right? Do you have a history? Has this ever happened before? Especially asthmatics, right? Hey, have you ever had an asthma attack this bad? Have you ever been intubated? Always a good question that you want to ask, okay? the last time you went to the hospital, what was your diagnosis? What did they tell you was wrong? Do you have the paperwork from your last hospitalization? Because sometimes people don't read it, don't know what their diagnosis was. Okay. Do you have any chest pain associated with this? Is it in the center? Is it off to one side? Did you feel a popping sensation? Maybe they have a pneumothorax, right? A lot of different things can cause respiratory issues. You want to ask good, thorough questions. What happened? What were you doing when it started? Right? Well, I was running and I stopped running and I can't breathe now. Okay, has it gotten any better? Yes, it's getting better now that I've stopped running. Okay, sounds normal. Does anything trigger you, especially asthmatics? Oh, they know. I had a partner once who she was severely allergic to cats, and if she went into a house that had a cat, her asthma would flare up and you would be treating her as well. Okay, so hey, do you know what your triggers are? Most of them do. Most patients do. Did it come on suddenly or was it gradual, right? Gradual kind of gives you an idea that maybe it's like an ongoing chronic issue. Might be CHF, right? Are you taking all your Lasix? Are you putting out as much urine as you usually do? Did you start eating maybe some extra salty foods? The holidays. CHF patients always do poorly around the holidays because the food that they're eating is extra salty. Do you have pain? Anything hurt? Okay. Position. Usually patients who are having shortness of breath want to sit up, right? They want to sit up, they want to lean over because it helps them breathe better. Little kids will lean back because it expands their chest, but as an adult, they'll usually lean forward. Do you have pain when you breathe, right? Were you involved in a car accident and maybe broke a rib and now you don't want to take a deep breath because it hurts? Okay. A lot of different things that can cause respiratory problems. So make sure you get a good history and look at the clinical picture as well. Do you have discomfort, right? The point with one finger thing is really helpful because you'll have patients like, oh, it hurts everywhere. Well, where does it start? Give me an origin, right? Use one finger to point out where it starts. Does it radiate? How bad is it? How hard is it for you to breathe right now? If you had to give it a number on a scale of 1 to 10. Having pain? Is that pain on a scale of 1 to 10? Is this the worst? Most of the time, patients will tell you, like, yeah, this isn't too bad. I just really can't catch my breath. And what have you maybe done to fix the problem, right? Have you taken an inhaler? Have you taken your steroids? Are you doing a nebulizer treatment? What have we tried to do to fix what's going on before I got here? I think it's 5 asthma pumps. The meter dose inhaler equals 1 nebulizer. Okay. So if you have patients who said, yeah, like I took 10 hits of my pump, okay, that's about equal to about 2 nebulizers. All right. I've had patients say that and you're like, wow, that seems like a lot. But in the grand scheme of things, it's not that bad because it's such a small, they're getting such a small dose from the rescue inhaler. Always ask this question, especially your asthmatics and your COPD patients. Have you ever been intubated? When's the last time you were intubated? Okay, these are all things that are important, right? Because it's going to keep you on your toes because that patient might go from talking to you to completely in respiratory failure because they might be that severe of an asthmatic. Other things can cause pleuritic chest pain other than just like, your cardiac issues, right? If there's some sort of tumor, a pulmonary embolisms, cancer, pleural effusions, any of these things. Very like, if patients have been coughing for a long time or aggressively coughing, you might see that they've, got some irritation in their chest wall also, like the muscles are just tired and irritated. Most of the time, if you have a patient who is having a hard time breathing and they are tachycardic and have an elevated blood pressure, I'm less worried than a patient who's bradycardic and hypotensive. Okay. Carpal pedal spasms, you most of the time you can see those from the door too, right? You'll see a patient who's like, can't breathe. You're like, you are hyperventilating. Okay, cool. Head bobbing is bad. That's a sign usually of fatigue. Okay. Is your patient putting out any sort of sputum, right? What color is it? Yellow is usually a good sign there's an infection going on. Finger clubbing, right? It's a sign of COPD, ongoing hypoxia. Could also be due to something like, cystic fibrosis, right? If you have a younger patient who's a little too too young for the COPD. We use pulse ox and capnography, right, to do some diagnostic and find out what's going on. We don't really have peak flow meters in this region, but it's a possibility. They use that a lot for asthma patients to see what they're up to. We talked about this a little bit when you initially learned about carbon end tidal, okay? Just a little quick review, right? So if you have a sudden loss of waveform, either the patient has gone into arrest or your tube is dislodged or there's some sort of blocking. Top right, shark fin. You should always make sure if you have that shark fin kind of line going on there, that's usually a restrictive airflow, okay, that the air is having a hard time getting out, and you see that in your asthma and your COPD patients. Right, so all of these things are waveforms that you might see. Bottom left is always nice when you have a return of ROSC. All of a sudden your end tidal starts going up because there's nice, suddenly good blood flow back to the lungs. Different pathologies, right? So you have obstructive airway disease. Most of the time these things are brought to you by predisposing factors. Genetics, right? Asthma is usually considered genetic allergen kind of based autoimmune problem. Okay, they have a lot of different ideas on what causes asthma. And then you have chronic bronchitis and emphysema, both of which tend to revolve around patients who have done some abuse to their lungs over the years, right? So a lot of the times there is a level of overlap with these diseases. You don't really see one kind of by itself. They all kind of hang out. And I don't know if that's because they don't want to put necessarily a single name on it, or because once you start futzing around with your whatchamacallit, once you start futzing around with your lungs, they don't like to feel like that anymore. So chronic bronchitis is clinically diagnosed as a productive cough present for most days for 3 months for at least 2 years without any other cause. So if you have a patient who is cystic fibrosis and they're constantly coughing because of that mucus, it's not considered chronic bronchitis. Most of the time, chronic bronchitis is because all of a sudden the lungs has excessive inflammation, they create excessive mucus, and they are trying to get all of those secretions out. So there is the type of VQ mismatch that we see, right? The ventilation perfusion mismatch is that you're not breathing enough. There's low oxygen levels and high carbon dioxide. So your patient will have issues. The bronchi are usually too large, and there's scarring of the lung tissue from frequent infections. So the lungs aren't working as well as they should. Then you have emphysema, okay, whereas in chronic bronchitis, it's hyperventilation, right? You have that barrel chest. They can't get the oxygen out because they have destroyed those little teeny tiny alveoli, and now they just have big old air sacs. There's less surface area, and then that residual volume increases because you lose the elasticity of the lungs. It starts to stiffen up, okay? That's why you see that barrel chesting. Because of that, you have VQ mismatches, a reduced surface area, and more resistance to air, okay? But because you also have those hyperinflated lungs, it's harder for blood to get into the lungs to exchange. And once you have that loss of elasticity, you end up with those bulla and those blebs, right? Those little aneurysms that pop up, and that increases the risk for pneumothoraxis. So you'll commonly see, they call the chronic bronchitis patients the blue bloaters, right? They're overweight and they are cyanotic, whereas your emphysema are your pink puffers, right? They're really kind of frail looking. Because they spend a lot of time trying to breathe. They have a lot extra of metabolic drive, so they get kind of skinny. That doesn't necessarily mean that they are not, again, there's no overlap, and you won't see a patient with COPD who also has chronic bronchitis falls into like the in-between kind of level. Hypoxic drive. Okay, we hear about this. We do this in BLS. Most of the time, your brain normally uses carbon dioxide to determine what your respiratory rate and depth should be. When you fall into these obstructive lung disease areas, right, where you're chronically holding on to too much carbon dioxide, it doesn't work anymore. Your brain's like, I guess I should be breathing all the time. And it's like, no, wait, this is wrong. So it switches to what's called the hypoxic drive, and it starts to determine your respiratory rate and depth based on your oxygen levels. Okay. There is always that, oh, don't give your COPD patients too much oxygen. If your patient is short of breath, give them oxygen. It's your job to keep an eye on them. The thought is that if you give them too much oxygen, you'll reduce their respiratory drive, you'll cause them to become altered and then go into respiratory failure. If you are not monitoring your patient and they become altered or become, that's your fault. You didn't monitor your patient well enough. Give them oxygen if they are having a hard time breathing and keep them a good look. So the emergency medications that we use, especially as ALS, you're starting to expand your toolbox a little bit. So we start in BLS, we have albuterol, right? That is the #1 emergency medication for asthma, COPD, right? It is a bronchodilator. It stimulates your beta 2 receptors, right? Because you have 2 lungs. And it expands everything. It relieves that bronchospasm. Now we're also introducing ipratropium or Atrovent, okay? So where albuterol works in your sympathetic nervous system, ipratropium works on your parasympathetic nervous system, and it starts to reduce it. It is not, rather than a sympathomimetic, it is a parasympholytic. So it blocks your parasympathetic nervous system, which reduces your mucus production, okay, and it prevents constriction, right? So rather than promoting dilation, it prevents constriction, okay? So you're hitting the same mechanisms from 2 different pathways, okay? So either way, you're going to make sure that those lungs are open. And then you add solumedrol or dexamethasone. Those are your steroids. Those steroids also help reduce mucus production and reduce inflammation by stabilizing the cell walls, okay? So by stabilizing the cell walls within your respiratory system, they keep the fluid from leaking out. And the fluid leaks out is what produces mucus, okay? So combined, those 3 medications do a lot to help reduce patients' difficulty breathing. Here's some asthma info, right? We know kind of generally that asthma is reactive airway. Something will trigger a patient and they'll start having that restriction. Asthma attacks can last for an extended period of time before a patient really notices that it's getting bad, especially if they're kind of maybe a more mild asthmatic. They might have, might be able to kind of manage it a little bit more before they feel like they really are having a hard time breathing. Asthma attacks happen in 2 waves. You have the bronchoconstriction, and then you have the mucus influx. This is why we give the solumedrol. Solumedrol and Decadron are one or the other, depending on which one your agency has. Good question. But this is why now as ALS, we can give those medications, okay? Because now you're helping prevent that influx after, because that influx is going to happen a couple hours after you treat the initial bronchoconstriction. So again, your VQ mismatch, you have an increased airflow resistance, so there's not enough oxygen getting to the alveoli, but there's also not enough carbon dioxide coming out, okay? Most of the time, deaths from asthma is when the patients go into status asthmaticus and start becoming asphyxiated, right? Because they can't get oxygen in and out. Imagine being strangled. It's the same thing, but from the inside. Your lungs start to essentially shut down. All that high pressure reduces your ability to move air, and then it starts to reduce your ability to move blood because you're just creating essentially a giant roadblock inside the chest. Other medications that we have at in our medication toolbox are MAG and epinephrine. They have changed the protocols that you can give MAG to COPD patients as well. I don't know if that's come down in the city yet. I have to double check. But epinephrine is usually only used for patients with asthma because you don't want to put an extra strain on COPD patients' hearts because generally they are the older group. so you don't want to hurt them. But epinephrine, if you see a patient looks like they're really crapping out, epinephrine is fantastic for that. Silent chest is a deadly chest. If the patient is not moving air back and forth, they are in status asthmaticus. They are going to die. They need epi. They need your support. They need to be tubed. Okay, these are patients who need to be treated aggressively. Okay, if they are sitting there just like gasping for air and you don't hear any air moving, that is a dangerous patient. Okay. Repeated doses of bronchodilators aren't going to work. This patient needs epi, needs their ventilation to be taken over so that they can breathe effectively. There are other things that can cause wheezing. All right. I know we have in the city, we had the wheezing protocol, but other things can cause wheezing, right? Like pneumonia, any sort of toxic inhalation that's caused some sort of damage to the lung tissue. Okay. Maybe cause some sort of level of swelling because of that damage. Heart failure, pulmonary embolisms can increase the amount of fluid that comes kind of rushing into the parts of the lung. Pneumothoraxes can have a little bit of a wheeze. Foreign body airway obstructions, if they're kind of in that like in between spot and they're not fully obstructing the airway, they can come out with a wheeze rather than stridor. Okay, so make sure you're getting a good patient history and and a history of present illness to kind of help dictate which pathway you're going to go down. Pneumonia. Go ahead.
Nicole,
Yes.
the only thing I didn't see on there, which so I'm just gonna, full disclosure, parent of a intubated asthmatic. So I've been down this road like more times than the average person. The CPAPing the nebulized medication
Yep.
for somebody who's at that beginning level because they can't get they don't have the mechanical ability to get that air in, but sometimes that CPAP can get the medication where it needs to be. So that's
Absolutely.
worked fairly effectively at times.
You just need to make sure if you're CPAPing a nebulized medication that you have two sources of oxygen. One needs to go to the nebulizer and one needs to go to the CPAP. Okay,
Depends on the CPAP, right?
for the most part, but a lot of them do require two source for it to be most effective. You can potentially nebulize through the one source depending on which CPAP nebulizer combo you have. But those are usually more expensive and you don't see them necessarily as much depending on where you are. Thank you. Mag is not COPD in the city yet. It's just out in Nassau and Suffolk. So pneumonia, okay? Pneumonia can be bacterial, viral, fungal. It could be caused by a patient aspirating, getting something that is not oxygen into their lungs, okay? Most of the time, what differentiates pneumonia from other concerns is really the fact that the patient is also potentially having a fever, okay, right? They might not be really hot to the touch yet, but it could be going on for a little while. They have a productive cough. It has color to it, right, that you're not necessarily looking forward to looking at. They might have some pleuritic chest pain when they cough, right? You can treat a lot of the wheezing from pneumonia with a nebulizer. Reason that it wasn't what, Anthony?
No, I was asking about the previous question with the mag where it splits in the protocol in the city, like there's a split, and I just don't understand it, and I feel like I don't know. I had a call the other day, and I was redoing the protocol in my head, and then I looked it up, and I was like, why is there a split there?
So basically, they don't 100% know why MAG works. They believe it is a muscle relaxer. It's like it relaxes the constriction of the muscles in the bronchioles.
Yeah.
But when you're dealing with COPD, it's not necessarily that there's a constriction. If you have a
Okay.
patient who has COPD and asthma, then you're like, oh, okay, this will work. But there's no guarantee that the patient is COPD and asthma. Because we do see that there are a lot of patients who have that overlap. If you're going, I am treating this patient under the asthma protocol, okay. But you just need to make sure that you are, so COPD is more about the elasticity. You're not going to relax the lungs because the lungs are already stretched to the max in COPD. But if they do also have a concurrent asthma history, you can also kind of work that mag in. Again, it's about how you document.
Yeah, so that's basically, I just wanted to make sure like I was like completely understanding the mechanism of the med.
Absolutely.
I don't want to be like, you have meds and like, it's like I want to know why, and not just because the protocol says so. I wanted to like understand it.
No, that's good. I want you guys to understand it. Good. Um, so pneumonia, right? We are all probably relatively familiar with pneumonia. The VQ mismatch caused here is that there's usually a consolidation in a part of the lung because of that junky bacteria or viral content, the mucus, and purulent discharge, which reduces the available surfaces for ventilation. Community-acquired pneumonia is usually seen in your nursing home patients, but pediatrics and geriatrics might not have that traditional presentation. They might have like a gentle cough that might not be very productive. I can't tell you the number of times that I see patients who have gone septic from a UTI. It goes straight from the urinary tracts right up to the pneumonia. Okay, up to the lungs. All right, so if you have a patient who's complaining more of urinary tract symptoms and maybe has a light cough, you might see that they are actually dealing with, both. Here we go, different types. Aspiration pneumonia happens a lot in your elderly, right? Once you start losing a good chewing and swallowing mechanisms, aspiration pneumonia becomes a problem. Also very popular in your narcotics overdoses who vomit, drunks who vomit and then lay in their own vomit. Happens there a lot. Again, you're not really changing anything that you're doing. I'm a huge proponent of IV fluids in pneumonia patients. You don't realize how much fluid you lose respiratory wise from, just regular breathing. I think it's like a few hundred milliliters a day you lose just from breathing. So if the patient's working really hard to breathe and then they have junk in their lungs, that's going to consolidate as they start to dehydrate. Sometimes that IV fluid really helps them cough and get that junk up. ARDS, who are not necessarily going to be treating ARDS. This is something that happens later in the hospital, okay? Basically, your lungs start to shut down because there's a massive amount of inflammation going on in the body as a whole. So it just becomes overwhelming and the lungs start to shut down. If you start moving into a more critical care kind of part of life, this is something you're going to cover a little bit more in depth, but do understand that ARDS is very good at killing people. Basically, the lungs start to fail. You have wet, heavy lungs. They're very congested. And then they require higher and higher levels of ventilatory support to breathe. So these patients are on like ridiculous PEEP in the hospital, and it can happen no matter how healthy the lungs were beforehand. PEEP helps reduce the oxygen toxicity that is possible. And it becomes kind of a very careful balance of trying to make sure that this patient is good. Again, you might see this in like if you're doing critical care or if you're doing like just interfacility transport. A lot of the times you're going to be focusing on maintaining the settings that the patient was already on. Most of the time, death is the first symptom of pulmonary embolism. Becomes this massive problem, right? Patients start having a hard time breathing. They might have sudden chest pain, and then they drop. Okay, any sort of syncope, that patient has a syncopal episode and then wakes up with a hard time breathing is a pulmonary embolism until proven otherwise. Most of the time, it starts as a deep vein thrombosis that gets dislodged and goes into the lungs. A lot of risk factors with, this is the wrong slide. There it is. A lot of the risk factors include sitting for long periods of time, like, I don't know, in an ambulance, and birth control and smoking combo, also not good, all right? Basically, you can ventilate these lungs well. They're doing what they're supposed to do, but there's no blood return to the heart. So you need to make sure that the blood return is coming back. Hopefully you catch a pulmonary embolism before they start getting into this really severe dead lung. It's essentially a heart attack of the lung. Virchow's triad for pulmonary embolism is super high coagulability, stasis of the blood, and a vessel injury, usually what causes a DVT or other mechanism. Any patient who's had an extended period of travel or prolonged bed rest, a long bone fracture, right, hips, etc., pelvic fracture, varicose veins are a risk factor also. Okay, any of these things can cause a patient to have a pulmonary embolism. Pregnancy causes hypercoag, autoimmune diseases, sickle cell, all right? Again, any of these things can cause it. You should have a high level of suspicion for pulmonary embolism. Right there on that right side, that consolidation, that's like that heart attack in that lung. You might see the changes in the EKG, okay? It's the S1Q3T3 pattern, doesn't always show up. You have to look carefully. And you look carefully, it might not be 100%, but you have a big S wave in lead 1, big Q waves in lead 3, and inverted T waves in lead 3 as well. Again, you cannot see that. Definitive care, right? They'll treat them fibrinolytically, or they'll do a diagnosis. I apologize, but I have a 10 o'clock meeting with my boss, so I need to step out. If y'all want to hang out for a half hour, or if you all want to come back, or just watch the group and come back when I'm done, we can do that, or we can pick the rest of the lecture up later, in the next lecture. What's today? Today's the 15th, so Monday we can do everything. Hopefully we'll be there. So please throw it in the chat one way or the other what you like to do. But I have to go. So let me know what y'all like to do. Hopefully this meeting will be about a half hour. We go with Monday? Monday? Cool. All right. I'll see you all Monday. We'll finish up. All right. Have a great day, guys.